let me introduce to you our first speaker, who is Dr. James McKay. And Dr. McKay is a radiologist, and he is the medical director of the Broadway Imaging Center and the chair of our St. Pat's Radiology. So, Dr. McKay?
Thank you.
Welcome.
All right, well, welcome this morning. A nice small group. I don't know if I need this. If I'm talking too loud, just give me the sign, and I'll quiet down a little bit. They've asked me to talk to you today about mammography. I know there's probably a wide range of experience in the audience in terms of what you know about mammography and what you've experienced. For some of you, it's probably old hat and maybe some old information, but hopefully I've included some stuff that you haven't seen before. I framed this talk around answering some questions, and these are the first four. I want to talk about why we think you should have mammograms, go over who and should have them and when they should have them, and also I want to discuss a bit what exactly a mammogram is. Not everyone really actually understands that. And then also I want to talk about what the radiologist sees with the mammogram. There's lots of information out there. You see some of it on the tables. There's also some on a lot of websites that give you a lot of information about breast health, but not a whole lot of information about what we're looking for when we look at your mammogram. And I want to go over some of that and sort of let you see some of the challenges that we face doing that. And then also, I want to talk to you about what should happen if you get called back. Now, as I'm sure a number of women in this audience can probably attest, that can be a very scary thing. You get this scary letter in the mail, and just being human, the first thing we do is think of the worst thing. But I want to show you some numbers to show you that if you do get called back, the chances of you having cancer are actually very small. And I want to show you just a little bit of information to maybe make that a little bit less scary should it happen to you. So let's get started. So, screening mammograms, and here we're talking about asymptomatic women who come in for a screening mammogram. They don't have any lumps, bumps, pain, anything. They're just coming in for their annual mammogram. Why should they have them? Well, the bottom line is that they work. Since 1990, there's been a documented 20% decrease in mortality just from mammograms. That doesn't include any treatment. That's actually probably a very conservative estimate. There's some more recent data out of Scandinavia that suggests that the decrease in mortality just from mammography is probably more in the range of 30 to 40%, and maybe for some populations even higher than that. Mammography is not perfect. The estimate is mammography misses anywhere between 10 to 15% of cancers. There's a number of reasons for that. I'll show you some of those later, and we'll get into that. Sometimes you'll hear controversy in the media about whether mammography works or not. It seems like it comes up every couple of years. There was a big one a few years ago, about 6 years ago, big headlines, mammography didn't work. And that made big headlines when it came out. What you didn't hear later is all that was refuted. But mammography does work. Again, not perfect, but it's the best tool we have for screening. So who and when? Every year starting at age 40. This is also something in the past that's been a little bit of a controversy in the medical community to start at 40 or start at 50. The preponderance of scientific evidence really comes down now and recommends, recommends that we start at 40, that there's definitely evidence that that's helpful. There's a wide consensus of a number of organizations, including some of those listed, that we should start at 40, and those are our current recommendations. So what exactly is a mammogram? Well, it's a low radiation dose X-ray of the breast. Women are naturally and reasonably concerned about radiation exposure, as are we. We try and do everything we can to reduce the radiation exposure from a mammogram. And it really is quite small. The equivalent would be of getting a mammogram would be the radiation dose you get from just being alive on this planet over the course of about 3 months. If you do a lot of airline flights, if you live somewhere where there's higher natural radiation, the percentage is even lower. So it really is a very low radiation dose. This is an example of a mammogram. We may need to turn the lights down. I apologize. Some of these look great on the computer. Some of these project a little bit dark. As most of you in the room probably know, we get two views. We get views from the top and then sort of views from the side. We get those two views so we can cover as much breast tissue as possible, also so we can localize lesions we find within the breast tissue. There's the mammogram machine. The X-ray tube is up here. X-rays come down here. Here's the detector plate. Here's that paddle. And Here's an example of a woman getting that sort of view from the side. And what I hear about almost every day is this question Ellie from For Better or For Worse is asking: how flat are you going to squash it? And there's her answer. And so we don't like to say squishing or squashing because compression sounds more medical. So we call it compression. And why compression? Well, if you just step back a little bit, really the ultimate goal of doing this is to increase our accuracy. What we want to do is detect more cancers and have fewer unnecessary callbacks. And that's true of everything we're doing in mammography, every technique we use, and that includes compression. Specifically with compression, I mentioned earlier we want to decrease radiation dose. When we compress the breast, tissue's thinner, it takes less energy or less radiation to penetrate it and see, so that decreases your dose. Also, as you know, anybody here that's taken a picture, when you move the camera, things get blurred. Well, we're looking at little tiny, almost microscopic little things we're trying to see. And when you move and get blurred, they can actually just disappear in the background. So the compression helps with motion. And also it spreads structures in the breast apart so we can see better. You're taking a breast, a three-dimensional object, and you're projecting it onto 2 dimensions, so structures can get superimposed. And that can do a couple things. One, it can hide cancers within that tissue, and also can make it look like there's a cancer there when it's not, and make us have to call you back to figure that out. And just that's a little bit hard concept for some people to get. I just wanted to sort of give an example here. These ovals, you can imagine that as breast tissue. It's relatively translucent, but when it's superimposed, it makes it look like there's a mass here. As we add compression to the breast and those tissues spread apart, that mass just sort of disappears. And I'll show you a real-world example a bit later. You guys see that one? I don't know if you've seen that one before, but this squishing or compression thing comes up a lot. And what I'd like to mention is that, women are different, and some women have very sensitive breasts. And if you know your breasts are really sensitive, then I would really work with the technologists. They're very caring people. They're very good. They'll work with you, tell them your needs and concerns, and they'll try to make you as comfortable as possible. For women who are premenopausal, who know your breasts are more sensitive during certain times of your cycle, I would encourage you to schedule your mammogram accordingly. And then I would also like to say that try and remember that it's going to be a relative brief experience with possible lifetime consequences for you. And I know I'm on thin ice saying that because I don't get them, and that's what that slide's all about. My wife thought this was pretty funny. You can see it's a manogram and not a mammogram. And my wife also pointed out she looks a little like Hillary, maybe even. So we'll move on from that one. And so we'll talk about just breast tissue a little bit. As you guys all know, breasts look different on the outside. Well, they look different on the inside too. Breasts are basically composed of glandular tissue, fatty tissue, and connective tissue. Women have different proportions of those within their breasts, and they can be sort of spread out in the breast in all kinds of different ways. Makes breasts what we call very heterogeneous. They can just look really different. That's part of the challenges of mammography. Here's an example of a very fatty breast. You can see there's a, you can see that there's a little mass here that really kind of jumps out at you. We see this with some frequency, not the most common pattern. This is probably a more common pattern of what we see with mammograms. You can see, there's a little bit more density here. This is some more fibroglandular tissue. Here's fat. You can see this fibroglandular tissue. This is the outer part of the breast, upper part of the breast. That's where fibroglandular tissue tends to first sort of develop or be more prominent. You can see there's another sort of pattern where we're getting even more dense tissue. And then here you can see this is an extremely dense breast. We've seen we've seen this one before. This is that fatty breast. This is that dense breast. You can see how this little mass just jumps out at you on the fatty breast. You can imagine if you move that over in this breast, it might just disappear in here. And that's one of the challenges of mammography, and that's one reason for that 10 to 15% rate of breast cancers we just don't see. They're just totally hidden. So what are we looking for? When you come in, you get your mammogram, you go, kind of goes to this dark hole where the radiologists live, and we look at your mammogram. What are we looking for? What are we trying to find? Well, first I want you to know that we are looking very closely, okay? You may not realize this, but we actually look at all your mammograms with these magnifying glasses. This is film mammography. We do digital now, but we still have film mammography for comparisons, and we still look at them. And like I said, we use magnifying glasses. Sometimes we use even this goofy thing, which is like a magnifying glass with kind of down a long tube, so you block out all the extra light. You can really zoom in on a small portion of the mammogram. And this is a digital mammogram, and when we move to digital, it's sort of put more tools at our disposal. We can magnify the breast easier. We can have computer programs that help us find certain structures that we might want to look for. We actually have an electronic equivalent of that handheld magnifying glass that we can actually move around and look at different parts of the breast. I put this slide in just as a reminder to tell you that it's really important that we have your previous mammograms to compare to. As you can see, these mammograms, as I said, are very heterogeneous. There's a lot of glandular tissue all kind of spread around. It can be very hard to find cancers in tissue like this. It really helps us to have a comparison from before, because that's really one of the keys that we use to be able to detect a cancer, is seeing a change. And if we don't have a previous, if I don't have a previous mammogram, I really don't want to, and you have one out there somewhere floating in space, different institution or somewhere, I really don't want to read your mammogram unless I have it, because I don't want to miss a cancer, and I don't want to call you back for something that I don't have to. And my best tool is the previous mammogram. So let's look at some breasts, and we look for a variety of things when we look at the mammograms. Two of the things you're probably most familiar with are masses and calcifications. We'll look at masses first. It's the third time you've already seen this breast, a fatty breast. Here's a mass. We look at certain characteristics of masses. They'll make us either more or less suspicious about could they be a cancer. To my eye, I look at this, the margins are really well circumscribed, or really smooth, kind of kidney bean shaped. This is up in the upper outer part of the breast. I know lymph nodes live there. To my eye, that's a benign looking mass. That's a lymph node, very common. Here's another breast. This mass sort of jumps out at you. You see it on this view and this view. Kind of looks like the one we just looked at, a little bit bigger, not quite kidney shaped, but the margins are really nice and sharp. But you notice it's living somewhere different. The other one was up in here, up in the upper part of the breast. This is down in the lower part of the breast. I don't know what that is. That patient's going to have to be called back. This is a more subtle one. I apologize again. This is a little bit on the dark side. There's a little structure here that wasn't there on the previous mammogram. It projects over here. I don't know what that is. That patient will be called back. Here's another mass right here. This is the upper outer part of the breast, kind of like where that lymph node was, but it looks a little bit different. Now here's a mass. I don't know if this is jumping out at anybody. This jumps right out and kind of screams at me when I look at this mammogram. This is sort of the textbook type of cancer in a breast. It's right here. You can see it almost has these little sort of what we call spiculations, little projections coming out of it. Sort of changes the architecture of the breast tissue around it. We'll look at this in a little more detail later, but that's sort of the classic picture if you look on websites or look in books what cancer looks like. Here's another mass. So this is another thing just to show you how it might be hard to pick this up if you didn't have the previous to look at. But here's a little mass right here that wasn't there on the previous. It's kind of hidden on this view, but it's here. Another example why we get two views, because it jumped out more in one view than the other, but we can find it. It's right there. And here's a woman who comes in. Looks like she has two masses. There's one right here, and looks like there's a mass here that almost looks kind of spiculated even. Here and here. So those are all examples of masses. The other thing we look for that you've probably heard about is calcifications. Now, calcifications are extremely common. Almost all women have calcifications in their breast. The vast majority of them are benign. We can look at them. The patient's dismissed, they come back in a year. But the reason we pay close attention to them is that sometimes calcifications can be a really early indication of cancer. So we're really tuned in to looking at calcifications. And this is an example. These are all benign calcifications. There's some little rounded calcifications here. Those are calcifications in cysts. These rod-like, real solid-looking calcifications, those are all benign. You'll notice there's some masses here. These are all benign calcifications. And I can say that just based on their morphology or the way they look. Here's an example, some more benign calcifications, a little bit different. Here you can see some of these sort of weird linear calcifications in here. There's some the rounded ones, there looks like there's a mass here that has calcifications in it. Let's take a closer look there. You can see there is a mass, has these sort of coarse calcifications in it. Those are benign calcifications. That's a fibroadenoma, which is a benign growth in the breast, very common as women tend to get older. They often develop calcifications within the fibroadenomas, and they look like this. These are calcifications within cysts, again, benign. And these weird-looking linear calcifications, some of you may already kind of figured out, that's calcifications in vessels. Those are arteries in the breast, and they also calcify over time. Here's a patient that has all three. Here's a fibroadenoma that's almost completely calcified now. That's like a rock right there. And there's some more of these secretory calcification cysts, and then there's some of those vascular calcifications as well. Again, those are all benign looking. What gets our eye are calcifications like this. And can you guys see this? Is it dark enough? Okay. You can see these little calcifications here. They're different than the other ones. They're really small. Most of them are kind of rounded, but the shapes are hard to say for sure. They're so small. This is a magnified view that's actually been magnified again by me on the computer. This is the same patient, same calcifications from different views. Hard for me to say for sure what those are. Those have some characteristics that make me a little bit worried. Here's another example. Again, same patient, different patient before, but these two are from the same patient. Same calcifications here and here. These, to my eye, just because the way they look here, are a little bit more benign, but I still can't tell for sure. And here's a breast. I know this is hard to see. There's some calcifications in here, and it's hard to see from the back of the room, but this is actually pretty hard to see when you're up close even. They're right there. We'll take another look. This is a magnified view of a magnified view. Those are those calcifications right there. You can see these are really punctate, small. That's a cancer. Those other two we biopsied, those were benign. Those first two cases I showed you, those were biopsied, those were benign. This was biopsied, this was a cancer. So you can kind of get an idea. It can be really hard to tell the difference between what's malignant and what's just a physiologic process that's benign and goes on in the breast. So that brings me to what if you're called back? Well, first, I want to emphasize that if you're called back, it just means we've seen something on your mammogram that we need to explain. You probably don't have cancer, but we need to take a closer look. And again, I'll show you some numbers later to kind of help emphasize that a little bit. I'm going to bring some of those mammograms we already looked at, some of those masses, and show you what it looks like when we work them up. Before I do that, I want to talk to you a little bit about what happens when you come in for a diagnostic mammogram. Those other mammograms, again, we're screening. You come in for a diagnostic mammogram. We're trying to answer a specific question. We'll do that by taking pictures from different angles, maybe do magnification views if you have calcifications and we want to see them better. We might do what's called spot compression view, which is compression but with a smaller paddle, so we really zero in on just one part of the breast. And then the other tool we use is ultrasound. Now, ultrasound's a lousy tool for screening, but it's a great tool for diagnosis because we can get a different look at tissues and masses and characterize them better. To my eye, this is a really pretty ultrasound. This is the skin up here. This is breast tissue. This here is the muscles in the chest wall. And you see this nice oval structure, really dark, really sharp margins, kind of a little bit bright behind it compared to over here. And that's pretty to me because that's benign. That's a simple cyst. It's not a worrisome mass. It's not going to turn anything bad. This patient comes in, we do an ultrasound, we see this, that patient's done, they come back in a year. There's another ultrasound. Looks a little bit different, but you can also see it's really well circumscribed, very dark. Again, this is the muscles in the chest wall. This is all in the breast tissue. There's a little bit of sort of these little floaty things in here. If you actually were to see this real time, it would look a lot like one of those snow globes that you shake that has a little snowflakes going in it. See it moving? It's just debris. It's still a simple cyst. This patient came in. We saw this. The patient went home. Now, how about this patient? We looked at this earlier. It's one of the first mammograms we looked at. Have this structure here. Let's take a look at that with ultrasound. Here it is under ultrasound. Again, the skin's at the top, chest musculature down here, and this is that mass. You can see it's solid. It wasn't just super dark like the other structures we looked at. Margins are fairly sharp, but not perfectly sharp, a little bit irregular. Hard for me to say 100% what that is. This was biopsied. It was a fibroadenoma, one of those benign growths. Here's a mammogram I put up to emphasize how much we need to have previous to look at. Again, two views. Again, it was right here where it showed up the best. It's also here. Patient got a spot compression view. It didn't go away. It's still there. There's the mass. Take a little bit closer look, different view. Still there. Margins are looking a little worrisome, maybe a little bit of speculations here. So let's take a look with ultrasound. Here's the mass. You can see it's even less well defined than when we looked at before. This was biopsied. This was a cancer. Now here's that ugly mammogram I talked about because it has this cancer. Again, this is a cancer that sort of read the book. It looks like they look in the books. Blown up view, again, you see, here's the mass, these little speculations, kind of changes the architecture of the breast tissue around it. Ultrasound of this kind of correlates to how that looked. See how irregular it is? On the edges, that corresponds to those little sort of striations you saw coming out from the center. This is a color Doppler ultrasound. We're looking at blood flow. This is showing a little bit of a blood flow to the cancer. And you can see how dark this looks. That's a classic cancer on ultrasound, just like it was on the mammogram. Now here's a mass right here. Hard to see on this projection. I apologize, it's kind of dark, but it's actually right here. This is another case that was probably picked up because there was a previous to compare to, because that doesn't look all that dissimilar from regular tissue. Do a spot compression view, it's still there, it doesn't go away. At this point, I don't know what that is. It could be a cyst, could be a mass, could be a fibroadenoma, could be a cancer. I don't know what that is. We'll do ultrasound. There it is on ultrasound. You can see that it's quite small. Here's the numbers. It's only about 7 millimeters in size. There it is. I'll get rid of those markers so you can see it better. You can see some of the margins are kind of well circumscribed, but not every margin is. That was biopsied. That was a cancer. Doesn't look all that different from that one to my eye. That was the one we looked at before. That was the fibroadenoma. So you can see there's a lot of overlap. That cancer there didn't read the book, really. It doesn't look like that at the one we looked at earlier. Now here's another mass. Here, hard to say what that is. Spot compression view. Still there. Margins may be a little bit irregular, a little bit hard to say. Do an ultrasound. There it is there. Now, I don't know for sure what that is. If that's my mom or my wife, that patient's going to get a biopsy. This patient got a biopsy. We did a biopsy with ultrasound guidance. Here's the mass here. This is the needle going right through the mass. That was benign. That was another one of those fibroadenomas. So I think you can see that there's a lot of overlap in the way things look. And so part of the reason it makes the job of reading the mammograms difficult. Now here's one of the last ones. We'll look at two more. This is the woman who looked like she had 2 masses in her breast. As you've probably figured out by now, this is nice and well circumscribed again. This is benign characteristics. But this is worrisome. This sort of looks like maybe there's almost some little speculations again on this. So we do a spot compression view, and I apologize, the spot compression view is a little bit dark, but this is that real-world example I told you I'd show you earlier from that summation artifact. This is why we do the squishing. This looks like a mass here. When we do that spot compression view, this mass really disappears. It's this tissue superimposed on this tissue, made it look like there was a mass there. There really wasn't a mass. This patient was done. They went home. They came back in a year. Excuse me. I'm sorry?
So there's nothing to say, there's still nothing to do with
For mammography, for as far as I can see in the future, you're always going to have compression.
I thought digital that there was some other way to do it.
No. Digital just means instead of having a camera with film, we have a camera that has electronic sensor, just like film pictures and digital pictures, okay? So this is an example of, I think, why we do mammography. This is a woman who came in totally asymptomatic, doesn't feel a thing in her breast. Look at the mammogram, all this glandular tissue, but some of your eyes have probably already gone to a place where my eye goes, and that's right here. Doesn't look all that suspicious, but doesn't belong there. That kind of dark, or on here, bright structure doesn't belong there. It almost projects off the film, but it's right here. Do a spot compression view. Here again, here it is. Here's the spot compression view. It's still there. It's real. Look at that with ultrasound, and there it is right there. And you can see how dark that is. This is actually, in case you're wondering, that's a rib. This is another rib. This is the muscles on the chest wall. It's quite small, but very dark, and if you look really close, those edges look just a little bit irregular. Here's another look at it. And so this was a cancer. This was biopsied. I knew this was a cancer before we even biopsied it, but it's a cancer. And like I said, I think that's a good example of why we do this, because if we can find cancers when they're small, like this, and the only way to do that is with mammography. If they're under 10 millimeters, that patient's almost always cured. I mean like 90% plus cured of the cancer. The whole key is to find them early. So I think this is a very good example of that. So I often tell patients, I kind of feel like one of these guys when I'm reading mammograms. I'm walking this tightrope. I don't want to have too many callbacks and create a lot of extra anxiety and discomfort and expense for patients. At the same time, I don't want to miss one of those early cancers that are curable. So I really do feel like I'm kind of walking this tightrope a lot at work. And I can tell you that in my job, I do a lot of different things. In the course of an average day, I might look at a CT scan of a trauma patient with a lot of really complex injuries. I might look at a brain MRI on somebody who has weird neurologic symptoms. I might do a CT or ultrasound-guided biopsy on a liver or lung or some other body part. But for me personally, nothing is more challenging than reading mammograms, especially tough diagnostic mammograms. There's nothing that makes me think harder or sometimes really want to pull my hair out like reading these mammograms. I think you can probably appreciate that seeing some of those examples. So I told you that we'd talk about what if you're called back, and I'd show you some numbers. These are some of the numbers I want to go through. This is all data that was taken over a period of a year from April to April here at Broadway Imaging. These are all digital mammograms. We kind of crunched these numbers just for the talk this morning. There were over 9,000 mammograms performed at Broadway Imaging in that time period. This is how many were called back. 681 out of 9,000. Some women feel like they get called back every year. Some women get called back almost every year. But you can see the majority of women don't get called back. That's a callback rate of 7.5%. I actually feel very, very good about that. The sort of national goals are to have your callback rate under 10%. Maybe a theoretical place to be would be at 5. Most places are around close to 10. I think this is a very good place for us to be in terms of our callback rate. So 681 women were called back or needed further evaluation. Of those 681, 440 or 2/3 were done. They came back, had their diagnostic workup, mammogram, maybe an ultrasound. They were done. They would go home. They got that scary letter in the mail and thought they had cancer, and they came in for one visit and they went home. They didn't have cancer. But there were about 1/3 that we recommended needed a biopsy. There was something on there. It's like some of those cases I showed you. It was hard to tell for sure what it was just by having pictures. We need to get a little bit of tissue to know what it was. So out of those 241, there were actually 234 biopsies that were done here. Of those, again, 2/3 of even the biopsies that we did were benign. So those women didn't have cancer. So that meant we did find some cancer, 31%, or 72 cancers. For those of you that are quick at math, you can see that doesn't add up to 100%. There were 11 additional cases where the women had an ultrasound-guided biopsy or a stereotactic-guided biopsy, which are biopsies we do in radiology. And the pathologist says, I just need more tissue. There looks like there might be some precancerous cells near there. We need to know more. Of those 11 women who had to go on and have a surgical biopsy, 2 of those 11 were malignant. So again, did over 9,000 mammograms to find just 74 breast cancers. Still too many, but you can see that's a lot of mammograms to find 74 cancers. So actually it was less than 1%. So I hope that number just seeing those numbers break down that way kind of helps you a little bit should you get that letter. So sort of to wrap up here, mammograms, why should you get them? Well, bottom line, they work. They save lives. They might save your life. They're an imperfect tool, but they're the best tool we have right now. Who should have them? Women 40 and over. And when? Every year. And again, I'm kind of harping on this, but if you do get called back, I want to one last time tell you that the chances are you don't have cancer, and it's still a very scary thing, and I appreciate that it can be very frustrating to get called back and have to come in and go through all that. but I would not be spending a significant portion of my life looking through this goofy thing if I didn't think I was doing some good. And I can tell you that we're doing the absolute best we can here to try and find your cancers when they're early and when they can be cured. And here's that example I showed earlier of a curable cancer. So I hope, after listening to this, that you'll agree with me that our shared goal of finding cancers when they're small and curable is worth this. Because I think it is, and I hope you do too. So thank you for your attention. Have a good morning. Okay?
You made a brief statement that ultrasounds allow you to screen.
Yeah.
We have a lot of women that don't understand why they have to have a squat. They can have ultrasound. And I'd like to have something to explain that. And you explained it in your lecture to me that obviously you have to start somewhere.
Well, it's a lousy tool because it's, number one, it's you only see a small slice of the breast as you look through. As I said, the breast tissue is very heterogeneous. There's a lot of glandular tissue and that connective tissue that kind of gets mixed up in there. It can create shadowing, which is that darkness we see with those cancers. So you can mimic cancers. I can take probably any one of you in here and do a breast ultrasound and either totally miss a cancer or make it look like there's a cancer there when it's not. So it really is a great tool, again, for answering a specific question, but it's a lousy tool for doing screening. Okay? Okay? All right. Yeah?
When we move from one city to another, should we ask the hospital for our film former?
You should. Yeah, you should get a permanent transfer. They'll do that for you. Just call the department. They can take care of that for you. You have to sign a release since it is, part of your medical record, but they'll get that sent because it really is important. Like I said, I don't like reading them if I don't have a previous. So,
Thank you.
you're welcome. Anything else?
Do you check with the community department that has the X-ray mammogram there?
Yeah, that goes on all the time. Mammograms are constantly getting sent back and forth across town.
What I mean, I used to have them done out at community.
Uh-huh.
Do you have a record here of that?
Yeah, what they will do is when you come in and you get scheduled, they'll know ahead of time and they'll get your mammogram sent over from community. And so they'll bring them over, so we'll have those to compare to.
Before I mention to them that I have one?
No, I would always mention it to them. You're always your best advocate. They'll probably figure that out. They may not need them. It depends how many previous ones we may have here. So we may not necessarily need them, but it depends what we see. We might. But I would always mention that. You're always your best advocate. Don't assume that people are going to know stuff about you. You just need to speak up. Yeah. Yes?
How frequently?
And so I'm going to invite 4 very, very wise women to come forward, acknowledging that they will be in the living room sharing their lives and sharing their stories about their personal experience with our topic today, breast cancer. And I am going to really fight my own temptation to not tell the story of these women as I know them, because I need to tell you there is power, and there is integrity, and there is beauty, and there is a spirit that is unspeakable that each and every one of these women bring to us today. And so Carol and Lisa and Beth and Sandy, if you would please come forward and know that we are in very sacred space as we have this conversation. So, Carol, you want to start? And I'm going to ask you to use this microphone, even though we're in the living room together. It's really helpful to be able to not have to strain to hear. So please use the microphone.
Okay. I'll have to be kind of brief and go through mine quickly because I've been doing this so long I could sit here and talk the entire day. I am 50 right now, and I was first diagnosed with breast cancer when I was 34. So 16 years ago, I found the lump myself. I got chemo, radiation, had a lumpectomy, was told, slow growing, non-aggressive cancer, you've got like 98% chance of being cured. So I thought, okay, I do all this treatment, I've got it beat, got this made. And within a year, so within a very short period of time, I found another lump in my breast and a lump in my neck. And, then when they found that, they're like, oh my God, your cancer was much more aggressive than we had ever realized. Ended up going to City of Hope in California and had a stem cell transplant. And then after the transplant, about a month after the transplant, I went back and had breast reconstruction. And I had the free flap that he talked about. Dr. Hardy talked about where you take the tissue from your breast, totally separate it, bring it up here and connect it to blood vessels in your arm. And I was extremely happy with that. People say, would you do it again? I said, in a heartbeat. And they did mine, had the mastectomy and the reconstruction all in one surgery. So when I went to sleep, I had a breast. When I woke up, I had a breast. So I didn't really deal with any loss. So it was just kind of like, here I am again. And then I also went back and had the nipple reconstruction. My cancer was, they said, so aggressive at that time when I had the stem cell transplant. They said you could practically see it multiplying under the microscope. They said, it gave me the creeps, and they said normally with a lot of people they would do the surgery first and then chemo, but they did mine the other way around because they said by the time we do your surgery, it's going to be everywhere if we don't get chemo in you. So they said when I was done with the stem cell transplant, if you go a year, we bet you're probably cured. We don't think you can go any longer than that. And I went 6 full years. In the meantime, we had adopted a child because the stem cell transplant had made me sterile. So we adopted a little girl. And so I'd gone 6 full years and started having pain in my sternum and was coughing. And I immediately, called the doctor, and it took me, which was very frustrating to me, 8 months before I convinced somebody that my cancer was back. After a few months, then I started developing a pain here or there, and I kept saying, I think my cancer's back, and they kept saying, no, you've been cured. And then sure enough, after 8 months, they figured out, yeah, it was back. And it was back. Good portion of my spine, my sternum, 3 of my ribs, my hip, pelvis area, femur. When they told me that, I thought, when they were saying, yeah, it's back, and started telling me all the places it was, I thought, is he ever going to quit telling me where it isn't, So I was told that I probably had 1 to 2 years max to live, that I was only going to get worse. I would never get any better, that I would just keep getting sicker and sicker until I died. So at this point, finally, they were able to tell if people were what they call HER2 news positive. And I can explain that more if later if people have any questions about that. But anyway, it's a test they can do on your cancer, and they can give you a certain drug that'll help treat that. So they tested me, and it came back that I was extremely positive. In fact, they told Dr. Speckert I was one of the most positive people they had ever tested, which also showed why my cancer came back so quickly, because you have a very high chance of metastasis if you are HER2 positive. So they put me on Taxol and Herceptin, which is the drug to treat this HER2. And within 3 months, they did a scan on me, and my oncologist was like, oh my God, this is a miracle. I have never seen this with anybody with any kind of cancer that's gone to their bones, how much my cancer had decreased. And even during that time when here they were saying, oh, you're going to get worse and worse, every day there'd be something about me that was better. Like, this is kind of creepy, actually. The night after I was having all this pain in my sternum. And the night of my first treatment of chemo, I'm laying there half the night because they're saying you're going to die. And I was stressed out and couldn't sleep. And I finally fell asleep at like 4 o'clock in the morning or something. And I woke up and my pain was gone. Now, it's the first time the pain had been gone in 8 months. I am now out 7.5 years with cancer all over my bones. That pain has never come back in my sternum. Normally when you have metastasis and then you get put on chemo, they say you are given a chemo drug, lasts a certain amount of time, then the cancer figures it out and you have to switch drugs. And then every time we switch drugs, the chemo works a shorter and shorter period of time until you run out of chemo drugs, because there just aren't enough out on the market. For me, I've gone very long periods of time on the chemo drugs that have also given me a chance for maybe something else to come out on the market or something better. I really don't know why I've gone now 7.5 years with cancer all over my drugs. I'm not on pain medicines, I'm not on antidepressants, I'm not on anything except my regular drugs to treat my cancer. I was told about a year ago that, at least a year ago, that if you had 5,000 women and they all had a metastasis, that maybe 4 or 5 would be alive, probably not doing all that well, and that I'm not on pain meds, I work part-time, live a pretty normal life is pretty much just unheard of. And if I was somewhere in a bigger medical center where they did a lot of research and things like that, that they would probably be having people watching me very closely, looking at the drugs I'm on, looking what I eat, looking what I do, trying to figure out what it is about me that I'm able to keep going like I have been and why I'm still here. So that's kind of my story very, very, very quickly.
What do you think it is that kept you going? Faith?
Well, that's I'm very stubborn. My husband always keeps saying she's too darn stubborn to die.
What's your will?
My will, also
Your daughter?
my daughter. Yes, definitely my daughter. When things happen to me too, I'm kind of one of those people that, yeah, definitely at first I cry and feel bad just like everybody else, but then I'm pretty determined and kind of pick myself back up and say, okay, I can do this. I get back up there and I'm exercising on the little treadmill even though I feel like I'm going to fall off, And then also it's kind of a double-edged sword in the sense that I'm HER2 positive. That's definitely why my cancer came back and was so aggressive. But on the other hand, now they've developed these drugs that can treat that. And I was so positive, having so much of that's why some of these drugs work extremely well for me. So I think that's some of it too, is that then the drugs work so much better for me. But in other ways, I don't know, it could be a combination of things. I try to eat well. It's probably a combination in just the makeup of my cancer, I guess. So, they would love to know that. People would say, what is it about you that you've been able to do this? So, yeah.
My name is Beth Koch, and I had ductal adenocarcinoma in July of '99. And when I found that out, I wanted to get it out as soon as I could, and so I had a lumpectomy about a week later. And I decided on a lumpectomy because I wanted to conserve what I had and not have so much surgery. They did do a sentinel node biopsy at that time and found out I had a very small tumor in my lymph nodes and my axillary, and so they were able to find it because of that test. I went on and had chemo. I had adriamycin, Cytoxan, Taxol, and then I had radiation treatments. I had 33 radiation treatments over 5 or 6 weeks. And ever since then, I've been cancer-free. So I feel very lucky. I think one of the things that's very helpful is having friends and family and going to different things. Like I've gone to the Relay for Life every year since I was diagnosed. I've gone to the Race for the Cure a few times. I went to the Sisters in Survival support group I probably went for at least a year and a half or 2 years consistently. And that's really good because you can go and talk to women that are in the same boat, pretty much. You can ask them questions, which is very helpful. Anything else? Oh, I wrote down a few things. Let me just look here. I think that's about all. Mine was estrogen responsive negative, and I didn't have to take any tamoxifen or anything like that. But here it is, 9 years later. So healthy. So. Next.
Hi, I'm Lisa Lackner, and I am a new survivor, I guess. Hopefully I'm still surviving. I was diagnosed on 9/11 of '06. I think, and I'm a nurse, and I think one of the hardest parts for me with the diagnosis was that I had mammograms since the age of 40, and I was 51 when I was found my own lump, and none of the mammograms had ever picked it up. And even the morning, I found my lump on a Sunday, and other women have told me they just know. And I just knew. And I got really vagal and got pale and sweaty and just laid down because I knew once I found my own lump, I knew that it was cancer. And it was. Anyway, Monday morning then, which would have been September 11th of all days, went in to see my gynecologist, and he ordered a stat mammogram, as far as they can be stat, and it was still read as normal. But because the lump was sizable, the doctors did in fact, Dr. McKay, who was here earlier this morning, did an ultrasound and a needle biopsy, and it came back positive. And actually it was stage 2 by that time. So I struggled a lot with that because I felt betrayed by the medical world, that my mammograms had been normal. And I have worked for 30 years as a nurse, and I thought, well, geez, why in the world did I have all those mammograms and all those clinical breast exams? Because it never had picked it up. And the tumor was actually almost, it was 5 centimeters, so it's huge. And some of my close friends that could get away with it said, "Are you sure that wasn't your whole breast and not just your tumor?" So you got to keep your sense of humor too, I guess. Anyway, so they did an MRI. The left side was inconclusive. The surgeon and I decided that we would just go ahead with a bilateral mastectomy, because I thought, if they didn't find it when it was a 2-inch size tumor, they're not ever going to see it on the left side either. So the one thing that I would like to leave with you as the ever-engaging audience is that if you're, and I could kick myself now, but what can you do? You can't beat yourself up either. But I did a tremendous amount of literature search after my breast cancer diagnosis. And even since the 1970s, the radiology journals have suggested that if your breasts are dense, and every single mammogram I ever had, the report came back dense, 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 dense. And I really, really should have had an ultrasound done, because that's actually, it's not quite a standard of care yet, but highly suggested. So had I known that and had insisted on an ultrasound, I would not have gotten to a 2-inch size tumor. So if you get a mammogram report back that says breasts are dense, please insist. Take your sleeping bag and say, I'm not leaving until I have an ultrasound, because that would have certainly saved me a bilateral mastectomy. So that was kind of hard for me to, breast cancer can be such a is for me, it was just as much about my psyche as it was about my physical self, because I felt betrayed by one. I lost trust in the medical community, people I'd worked with forever, so that was hard. I didn't have any cancer anywhere in my family. All my grandparents lived to be 90 and just died of crankiness. Certainly no breast cancer, and I have a twin sister, so she and I enrolled in a twin study out of Toronto, Canada. And then I had a hair shaving party and invited my close friends, and we shaved my hair after, I don't know, there's quite a bit of tequila involved in that. And I remember it well because we had the hair shaving party and the tequila on the October, because I didn't want to have my hair fall off, because obviously with a 2-inch tumor I needed chemotherapy. So we had the hair shaving party and the tequila on the night we were supposed to turn the clocks back, because it was in October. And my twin called from Pennsylvania, and she said, after it was all over and she knew the hair was gone, she called and she said, how'd you do? She said, don't forget to turn your clocks. And I said, no, I don't want another hour in the most horriblest day of my life. So I'll turn the clocks when I'm good and ready. Yeah, you have to seize control where you can. And the other thing why I also lost trust in the medical world, and I'm just now getting it back, and it's been a year and a half, is that the MRI that they do after the mammogram was read as normal. The ultrasound and needle biopsy said this is anything but normal. It is cancer. You need an MRI to see if it's anywhere else. They did the MRI, inconclusive on the left breast, but they determined that the tumor in the right breast was 1.2 centimeters at its largest. Well, actually on biopsy, it turned out to be 4.8. I mean, when they took the breast off, it was 4.8. So they were only wrong by 400%. So the wrong MRI cost me another general surgery, and I had to be put to sleep again 2 weeks after my bilateral mastectomy, because Dr. Hardy and Dr. J and I decided that since my tumor was only 1.2 centimeters, I would qualify for tissue expanders, because I would not need radiation. There's an algorithm that you follow, and depending on what size tumor you have, depends on if you need radiation. Well, radiation usually starts around the 5 centimeter mark, according to the kind I had. And mine was estrogen dependent, was the kind of tumor I had. So Dr. J did the double mastectomy. Dr. Hardy was in the OR with her, and as soon as the mastectomies were done, he put in the bilateral tissue expanders. But then when the pathologist looked at the breast, the tumor was actually, like I said, 4.8 centimeters instead of the 1.2 that they read on MRI. So Dr. Hardy called me back into the office and said, Lisa, I don't know how to tell you this, but we're going to have to go back to surgery because you have to have that tissue expander back out. And I mean, that's like a $12,000 surgery, and more surgery and more anesthesia. He said, but you're going to need radiation. And I remember, dear Dr. Hardy, I went hysterical because, of course, I was just had it by then. I didn't trust any physician. I didn't trust any radiologist at all, because now they had goofed up tremendously on reading the MRI. And Dr. Hardy, you might have caught on when he was up here. He's very caring, and I was crying hysterically, and all he knew to do was go to try and find me something to eat. So he must feed people that are emotionally upset. He said, oh, there's cake in the office. Do you want cake? Do you want a granola bar? How about some apple juice? I said, no. Anyway, so back to surgery I went, had the tissue expander back out, more scars. more dreams. Had the hair shaving party, drank more than my share of tequila, which was wonderful, changed the clocks when I was good and ready, started chemo, got the portacath in, chemo went well, went back to work, had, like Beth, 33 radiation treatments, went back to see Dr. Hardy after all of the radiation and got the tissue expander back in and expanded both of them then, and the radiated side doesn't look nearly as well because, like Dr. Hardy says, radiated skin is a lot of scar tissue. But so all is well that ends well. I've met a lot of great people along this journey. I'm restoring my faith in physicians, I think mostly in part due to Dr. Hardy, who has been absolutely tremendously good. I think what surprised me, and in closing, and I'll pass this on to one of my heroes, Sandy, I think what surprised me the most was the emotional recovery, which has taken, and I'm still recovering emotionally, that has taken much longer than even all of those surgeries and breast reconstructions and whatever. And I went to the Native American Women's Breast and Cervical Health Conference yesterday, and like a lot of the Native American women said as well, losing the hair for me was worse than losing breasts. And my recovery and my emotional healing started mostly when my hair started growing back. So, yeah, now this is my real hair, no more wig. And I'm on tamoxifen now for 5 years. And so I think one of the positive, I think you can always find something, I believe, and it took a long time to believe this, but I do believe that you can find something positive out of every traumatic event. And I value actually my life more now because I do. I'm picky about who I spend my time with. I love life much more, even though I always was kind of a happy person. I value it. It's precious. I treasure it, and that's probably one of the positive things that have come out of this journey. So I'll pass the...
Carol's my hero.
Falling out now. I've
Is that
switched
she's
drugs, so
starting? We
mine's in
talked
the
about
process of probably another week. I'll be bald
Bald
here.
again.
So I'm like going. I've done this like 6 times at least that my hair's fallen out, and it is true about your hair. Every time I don't think it's any less traumatic. You go, it's just hair. It's no big deal, but somehow it's hard being a woman and being
It's
bald.
your hair.
So.
It's your hair. I'll try and keep it a little short. I know we're running over. I'm an 8.5-year survivor, and went through no radiation, but kind of everything else. My journey started a little different. I had been thinking a lot about breast cancer, and my friend said, why don't we invite our friend Anna from Billings, that we both knew when we used to work there, and get her to go to the Race for the Cure in Helena. So she said, okay. She'd been a survivor for about 4 years. So that was May of 1999, and we're up there, and we're sitting at dinner, and Anna's sister came. So they're talking about their mother died of breast cancer, their aunt died of breast cancer, and now Anna had breast cancer. So we went to the race, and Anna wouldn't wear the pink shirt. If you know, survivors wear pink shirts. And so I could pick her out in my pictures I took that year, because she's the one in the green shirt in the middle of all the survivors on the steps of the Capitol building. Of course, we were down below crying, Donna and Dorothy and I, it's very emotional, and you just feel it in the air there. And we left, and in July, Donna was diagnosed with breast cancer, her sister. And also then August, I'd heard about a friend of mine, and I didn't hear it directly. So I didn't want to call her. I thought, well, maybe this other person breached a confidentiality with us. So I just debated, and it was so painful to not call. And I thought, well, what should you do? And I got busy. And then in September, I was diagnosed So that's 3 out of the 4 ladies having dinner in May now all had breast cancer. And you think, oh, in my age group it's 1 out of 12. I already knew 12, so how could number 13, 14, and 15, and I'm 15, wasn't good. And so I called my friend, and I said, I'm sorry I haven't called. And she said, that's okay, we'll get through this together. And we did. So I thought I'd tell you a few of the humorous things along the way, because that's how I tried to get through things. So cutting the hair, I called my friend and I said, I should be losing my hair in a couple days. What do you think? She says, well, I'll just come over and buzz you a little. So she came over, and she has this little train case. Do you remember our mother's train cases, the little hard with the handle on top? I said, boy, that's old. And she said, yes, this was my mother's. She died when I was young, and I keep this forever. She had all her hair cutting stuff in there because she'd always cut her boy's hair. So she opens up this little train case, and out comes a striped sheet she puts on the floor of my house. Then she sets a stool on there for me. Then it's still not about me, right? It's all about her. She gets out this pink satin button-up nightshirt, puts it on. Still, I'm thinking, what is she doing? Then she gets little pink satin slippers out and puts them on and takes her shoes off. Then she sets me down, puts the hair cutting thing around me and says, okay, I'm ready. And I said, what is this? And she said, well, the hair doesn't get on my clothes. It runs off the pink satin, and it doesn't get on my shoes. It gets on the slippers. And so I looked at her and I said, the least you could have done was had your brown and white and black striped sheet match your pink satin. And we both started laughing, and she took my picture on the floor. I just doubled over in laughter, and I'm lying on the floor. So that kind of started my photo journey and journal of what I went through with breast cancer. Some other funny things that happened, though I don't want you to think I think breast cancer is funny. It's not. But these were the humorous things. There's always the sad stuff. With my friends and family, I just received so much loving care, and I'm an RN, she's an RN, she's an RN, she's an RN, and most of my friends, well, all my friends almost in our Sisters Survive, our own little group of RNs that have worked here. It's kind of scary, isn't it? But one of the things that happened was I was with Dr. Marquette, who's the radiation oncologist. I met with everybody at first, and I didn't know if I needed radiation. We weren't sure, but I thought I want to meet everybody first, make my plans, be in charge. I'm the nurse, you do these things. So I'm sitting in her office, and my pregnant daughter was there, and her little girl who was 2. And Dr. Marquette takes the paper on that exam table, rips it down to the end, pulls out where your legs go. And I thought, okay, I have to get up and undress. And she says, oh, no, I've looked at all of your information. You don't need to undress. She said, this is for me. I went, so now my haircut was for my friend, the tissue paper on the exam table is for Dr. Marquette. Nothing's about me. Then she gets this wad of colored pencils. And she starts drawing on the paper on the exam table, and she starts writing, okay, here you are. You had your mammogram. So she goes through my whole, what she calls my personal algorithm of, this is me, finally it's about me, right? And not just my breast. And she goes this whole thing, colored pencils, if you need, here's the surgery, this is what they could do, here's the oncologist, here's me, she says over here, if you need radiation. We don't know that. She keeps pulling paper down and more paper down, and gets this really wad on the floor. And we hear this, and she goes, come in. I already told Shar this story. And nobody was at the door. So she draws more, and my daughter asks questions. We ask questions, and you hear this, come in. She says, come in. Nobody's at the door. Well, we kind of noticed that my little 2-year-old granddaughter had scooted herself into the corner of the exam room. Guess what she was doing in her diaper? So it was her letting little toots on the wall that sounded like, the noise. And we're like, Ariana, and how they are. Poor little thing. So that we started laughing. There was some humor there. Another one of my humor stories I thought I'd share with you was my stereotactic breast biopsies. I'd already had 2 holes in me now please don't be afraid to go do stuff. We all have our horror stories. Like having a baby, you can't help but tell the birth stories. So this one was, I already had 2 holes in my breast. Isn't it funny, even Dr. Hardy had to go with his hands. He was always, you can't help, so yes, this is the one. I had 2 holes that hurt, of course, and I'm going in for my stereotactic, which is, the next level of biopsy and much more squishing. So the radiologist explained everything to me, but I go in the room and there's 3 people plus him in this little small room at Western Montana Clinic, and it was like, I couldn't breathe. And so they're telling me I have to have another mammogram, so I go down the hall, get a mammogram on this already sore breast with big holes in it, purple. Come back in, and then he tells me also that, the machine they put you in smashes you so flat for the stereotactic test that you don't need any anesthetic, because, of course, that ruins the biopsy anyway, but after a few minutes you don't feel the pain because, of course, it's numb. And I might be there quite a while. So I'm sitting there, and so you're, trying to get the gown over here, and then put your arm up here, put your head here, and you're just, and he says, well, another doctor's coming. You might know him from St. Pat's. He's going to learn more about these tests. So there I am with actually both breasts kind of exposed, and you're in this horrible position, and in walks a doctor that I always said hi to in the hall, and he didn't know it was going to be me, and he looks up and he goes, you could tell by his face, he knew me. So as he walks by, very, quietly, he touches my leg and says, I'm sorry. And as he walks by, I said, so am I. And I said, I think a man invented this machine. And he didn't get it at first, and he walked to the corner of the room over here, and suddenly I hear this little chuckle. He got it. And he says, he probably was a man. So during that week, someone sent me, I don't know if any of you have seen, it's called Manogram, and it shows a man in a gown, sorry, Carl, this, with the mammogram machine lowered below the waist. And it's called a Manogram. I almost sent it to the radiologist just to say, this. If a man had used this as his own invention, you wouldn't be torturing us women with this. But I didn't. I tried to be a little professional. So those are some of the humorous things that happened to me that I tried to look at as humorous. What I found helpful was that I was surrounded by many, many wonderful people. I had worked here at St. Pat's for many years, so I had lots of people hug me and kiss me like we do with everybody else. We're very good here. I don't work anymore, but this is where I was working. And one of the other special things I'd like to leave you with is that I was at the copy machine one day. I didn't have any hair. I can't remember if I had a wig on because I was always afraid nobody'd tell me they were crooked. It was crooked, So I had bought a lot of hats, and that's what I did. And my biggest thing was to leave my chemo and go find a new hat to wear. So I had lots of hats. Anyway, I felt these arms come around me from behind at the copy machine, and I turned around, and it was one of the maintenance men here at St. Pat's, and he had tears in his eyes, and he said, I'm really sorry, Sandy. And I said, yeah, so am I, thank you. And he said, well, if you ever need anything, my wife or I will come to your house, we'll do anything. And I thought, this is the guy I say hi to all the time in the hall, and those are the people that really come out of the woodwork to you when you go through breast cancer, and it was very wonderful, the people that came. So if you have someone, don't be like me with my friend and not call right away. She's back there. Call people up, take food out. Somebody called me once and say, hey, there's a frozen lasagna for you on 5 North in the freezer. Come up and get it. When I went, it was gone. So I thought the staff must have been really hungry because it had a note on it to me, and I thought, well, they used it, that's good, I don't care, but things would arrive at my house. You got funny cards are okay. You don't have to be sad. So touch base with people that are going through any kind of cancer because they do need you at that time, and just do something for them. It's really hard when people say, call me if you want something. It's really hard to call you when we want something. It's better to surprise us, isn't it? Yes. And I know these ladies. I know a lot of other women with breast cancer here in Missoula community, and I just hope and pray those of you who don't have it here or had it don't ever get it, but if you need it, there's a lot of support here at St. Pat's and good doctors, and I know Lisa had her moments. There are those stories too, but we are in a good place here for the Cancer Center and physicians here, but you need to speak up and be your own best advocate. So thank you. I don't know if there's any questions.